Hi everyone, my name is Lucas and I'm here to talk to you about how to see a patient with a blocked catheter. So I'm aware this is quite a practical subject, so it's probably quite limited with how much you can learn from a lecture. However, I'll try and give you some useful tips so that you can take that into your on-calls and into your day shifts to practice catheterizing patients and the theory behind it and how to manage their problems, because they do come with quite a few. So sort of our basic objectives for today is to understand the different types and sizes of catheters and understand how to manage problems with them. And a quick overview of what we're going to cover, so some brief anatomy, some different catheter types you can use, the difference between male and female catheterization and tips, some basic tips for those, and then the main sort of troubleshooting of catheter problems that you'd probably be aware of from your on-calls. So blocked catheter, visible hematuria and clot retention, and traumatic removal of catheter. So just some basic anatomy that's important to know for male catheterization especially. So the penile urethra is where the catheter first inserts, followed by the bulbar urethra, then the membranous urethra, which then follows the prostatic urethra into the bladder. So the main area of concern you will encounter is this bit here, the membranous urethra. So it's the narrowest part of the urethra and it's the most curved. So in terms of inserting a catheter, you can see where the problems may lie here. And trying to actually get the catheter around this bend is the main issue with male catheterization. And we'll come on to that a bit later. Some different sizes of catheters. So the main system used for catheter sizing is the French system. So between 10 and 20 French is what you're going to be using for urinary catheterization. And so you get called by the nurse to the ward. So they say, "Doctor, this man cannot pass urine, please can you catheterize him?" And you ask for an SBAR handover. So she says he's a 54-year-old male with a history of BPH. He's 3 hours post-elective inguinal hernia repair. He has a past medical history of high blood pressure and diabetes, and he's a smoker. So how would you approach this man? So obviously, first of all, you need to make sure he's stable and clinically well. So you do an A2A assessment, do a brief history and a brief examination. Reading the op note is a very important thing in this patient, and in lots of cases where if you get asked this in interviews about how would you manage a patient, every post-op patient you need to read the op note to see if there's any instructions or special considerations to be made. So only then, once you've done that and you're happy, you need to consider catheterizing the patient. So considering the size, type and technique you're going to use are the three main things you need to think of. So for male catheterization, you need to straighten the penile urethra, making sure that urethra is straight as possible, giving you the best chance possible for catheterizing the patient. Using a coude or a Tiemann tip catheter, they're the same thing, essentially is a curved catheter which will help get round that bend that we explained earlier in the membranous urethra. And I'll show you what they look like in a second. Different size of catheter is important, making sure the size is appropriate for the patient. And avoiding repeated blind attempts. Now this is probably the most important one, because catheters can cause serious damage that can cause problems for patients. So always call for help if you fail a couple of times. I think twice is probably a good guide to attempt catheterization, and then call for help if you can. So this is the Tiemann or coude tip catheter. So I'll just show you the curved end of the catheter will help sort of guide the catheter around that membranous urethra. So when you're inserting it, make sure you keep this tip in line with the balloon port, so you know that what's facing upwards. So if the tip is facing downwards, it's not going to have any benefit. It's probably going to make it even harder. So making sure that tip is facing upwards as you're looking at the patient. So for female catheterization, the main issue with female catheterization is sort of to do with anatomy. Actually finding the urethra is often more challenging, especially in overweight patients. So my tip with this is the more hands the better. So get one person either side to hold the legs apart and hold the fat apart and things like that if need be. With practice talking to the patient as you're doing so, and that will probably give you the best chance for female catheterization. Next, so the catheter goes in perfectly, and you're very happy with the job you've done, but the nurse actually calls you back saying the catheter is bypassing, and please can you come and sort it. So what does this mean? So bypassing is essentially the urine is not coming out of the catheter, it's actually coming around the sides of the catheter, and what should be going through your head is that this catheter is now blocked somewhere. So I've created a little flow chart here. So the first question you need to ask is to the nurse, have you tried to flush it with a 50ml bladder syringe? And this often works and may require you not to come to the patient, but if they have and it's still blocked, then you need to go to the patient yourself. So I recommend sort of trying to flush it yourself if you're confident, up to 2 times again. If it retracts easy when you're aspirating the water, then the catheter is unblocked, and you might actually see what was blocking it in that aspiration, and then discard that liquid and ask nurses to continue monitoring input-output from there, and your catheter is unblocked. But sometimes if the syringe is pulling back, so you're pulling the syringe outwards and it's withdrawing and resisting you, the blockage is still there, and if after those couple of attempts it's still not working, you need to change the catheter, because there's probably a blockage in it that isn't amenable to aspiration. So remember, only flush if you're confident and in the absence of any contraindications. So if there's a bladder perforation, for example, don't do any of these without any senior input. So you've unblocked the catheter, but again, you're called back and the catheter is working fine, but it's starting to pass frank hematuria, so frank blood in the urine, and they ask if you can help. So the things I would want to know from this is, what's the patient's history, if you don't know it already? What does frank mean? What does the nurse actually mean by frank? Because there's a bit of a variability there. Essentially, what does the blood look like, and whether the patient's in pain or not. So managing visible hematuria, you need to go to the patient, assess the colour of the urine, and what you're looking for is the colour of the urine in the tube and not the bag. So nurses will often say, there's sediment in the catheter. What they usually mean is there's sediment in the bag, and a lot of the times there is anyway with anyone's urine, because that's where the urine collects and the bits sort of coagulate. So you need to look at what's draining directly from the catheter tube, and that determines whether the urine is clear or not. So the 2 main sort of types of visible hematuria described as rosé, which is sort of dilute blood in the urine, and you need to sort of investigate the cause of that. It could be a UTI. But the main one we worry about in urology is fresh red blood. So you probably need to have competence in managing this, or at least call for senior help, as the patient will probably need a 3-way catheter to irrigate the bladder to stop clots forming and to stop clot retention. So this is a 3-way catheter, so you've got an extra channel here, which is the irrigation channel to allow fluid to drain into the catheter, into the bladder, and then drain out of the catheter to allow that blood to continue draining and not form clots. Clot retention. So you need to ask, is the patient in pain? Is probably the most important question here, and it's one of the main complications of visible hematuria. It's very painful, and the catheter will stop draining, and you need to do bladder washouts with a 3-way catheter till the clots aren't forming, and then start irrigation. So irrigation is shown here. So you've got irrigation fluid coming through here into the catheter that way, and then the catheter is draining as usual into the bag, and this happens continuously with irrigation, stopping the clots from forming. And then finally, just traumatic removal of catheter. You want to make sure the patient's stable with an A2E approach. Is there any bleeding that's not stopping? If so, contact urology urgently, and use the major hemorrhage protocol if needed. If the bleeding stops, you can consider a recatheterization, but it's probably do an urgent urology referral that day or the next day. So just to summarise, male and female catheterization, I've shown you some tips there. Consider the size and the type of catheter, and consider a Coude or Tiemann tip. If you've got a block catheter, flush it or change it. If there's visible haematria or clot retention, you need to flush and irrigate the bladder. And if there's traumatic, remove the catheter and continual bleeding, you need a urology input. Okay, thank you very much.